So with each threat, with each infectious disease that I'm going to walk through, certainly the initial presentation of that threat demonstrated for public health gaps in access, gaps in equity, and gaps in trust that resulted in disparate outcomes. So the way this talk is going to be structured is a little bit going infectious disease by infectious disease by infectious disease. And we're going to start with what we knew when I first started to engage with that disease, what we know now, and what we've sort of learned and what challenges persist throughout that time. And I'm hopeful that you'll see there are opportunities that we can pull from each of these infectious diseases in ways that we can build a stronger, more equitable public health system for people here in Massachusetts and across the country. This next slide you sort of already heard, which is a little bit of my biography. I'm not going to go through it all. The reason I put it up here is just because I'm going to talk about years. So I'm going to talk about, for instance, HIV around 2012 to 2015. And that, for me, was a really formative time because it was a time I was going through my residency training. I was understanding that I wanted to differentiate into an infectious disease doctor and that I wanted to care for people with HIV. Similarly, you'll see here my time at CDC was 2021 to 2023, which was really the height of the COVID pandemic. I started the first week of February 2021 at CDC. People can put themselves back there. Vaccines were not fully available to everyone, only people in certain high-risk groups. All schools across the country were remote, right? Everyone was wearing a mask everywhere. It was a very different time. And then I stayed for 2 years until 2023, kind of going through the evolution of the COVID pandemic and through the Mpox outbreak of the summer of 2022. And then I've been at DPH since 2023. Okay, so with that grounding, we're going to dive in to the first disease, which is HIV. And again, we're sort of thinking back to what we knew back then when I first really started to engage with HIV, with those living with HIV, those at risk for HIV. Obviously, you know, the first part of this century, 2000 to 2010, resulted in a tremendous amount of change in the HIV epidemic, right? We went from 1996, the advent of triple therapy, antiretrovirals becoming available, HIV becoming a treatable disease, through to 2010, when we're on the precipice of pre-exposure prophylaxis, right? We had done a lot around behavioral health and behavioral change to decrease HIV acquisition. And so over those first 10 years of the century, there were declining rates of HIV incidence all across the country, including here in Massachusetts. And then around 2013, 2012, 2013, that decline stabilized, and we started to see this plateau all across the country. And what I'm showing you here are CDC data that show that plateau, but it was true in nearly every jurisdiction across the US. But despite that decrease and then plateau that we were seeing when we look at the national numbers, we knew that the burden was different by race and ethnicity. And so this is a figure from a CDC fact sheet that came out, actually not in 2016, a little bit after 2016, that looked at rates of HIV by race and ethnicity, and also by sexual orientation. And what you can see here, if you can see the small letters down there, is that while many groups did have a decrease in overall incidence of HIV, Black and Latino MSM in particular were not seeing that same decrease, right? So the first bar are Black, gay, and bisexual men. The second bar are Latino, gay, and bisexual men, where either we have sort of the same high-level number of new incident HIV cases or an actual increase in HIV incidence. And in fact, when we kind of break that down by age group, in the 25 to 34-year-old age group during that time period, there were these substantial increases in new HIV infections. It was also a really interesting time in the HIV space because in 2012, pre-exposure prophylaxis, specifically tenofovir, disoproxil fumarate, emtricitabine, or Truvada, was approved by the FDA. And it was approved after a series of studies that had come out that were looking at the efficacy of once daily Truvada to reduce the risk of HIV acquisition. When I was a resident, these were studies that I knew sort of like front to back. I knew every figure in every study because it was rapidly evolving what was happening in the HIV world. IPREX was the first study, was published in the New England Journal of Medicine back in 2010 and showed what we all thought was a remarkable 44% reduction in HIV risk by those who were taking once daily Truvada. And then with nearly every study that came out afterwards, that risk reduction increased to the point where we now believe, we'll get to modern day pre-exposure prophylaxis, but we now believe that pre-exposure prophylaxis is nearly 100% effective at reducing the risk of HIV acquisition. So in 2012, we had this amazing tool available, but no one knew about it. It was incredibly expensive, around $12,000 to $15,000 a year just for the cost of the medication. Obviously, we were hopeful for insurance coverage. Not all insurances were covering the medication. There were costs associated with laboratory testing. And there was incredible stigma and mistrust. And that, I think, is a really key factor in what was limiting our ability to address the HIV epidemic back in 2012, 2010 to 2016. And when we actually looked around that time period, this is a figure from an MMWR that came out in 2018, but it looked at data in 2014 and 2016 to understand who was actually prescribed pre-exposure prophylaxis and who was taking the medication. And it turns out it was really only white gay men that were taking pre-exposure prophylaxis. So this is broken down into 3 buckets. On the left, all PrEP users. In the middle, male PrEP users, which were predominantly men who have sex with men. And on the right, which you can barely see any bars, female PrEP users. And the dark bar are white individuals, right? So it was really just white individuals, white gay men that were getting pre-exposure prophylaxis. For me, I'm just going to give you a little insight into how I grew as a clinician and someone who was interested in public health and in my career. This really bothered me. I was right at the beginning of my fellowship when these data started to become available. It really upset me that we had an incredibly effective tool that was not being delivered equitably. And something that has always happened to me when something really bothers me, I feel like I have to write it down and get it out there into the world. And so I actually shared these 2 papers for you to review as part of the journal club, but these 2 papers came out, one in 2018, one in 2019, where I tried to outline why this is such a huge problem and why we were seeing this disparate uptake of pre-exposure prophylaxis. The one on the left was focused on men who have sex with men and walked through some of the barriers that Black and Latino men experience when trying to access HIV services. The one on the right was actually about largely why we don't see or we didn't see pre-exposure prophylaxis uptake in women, and it's because we didn't include them in the clinical trials. We didn't actually study the drug in 50% of the world's population. And that was a choice. It was a choice to design clinical trials that didn't include women. And it has real-world implications. It means not only do we not know the efficacy of the drug in that population, but we also didn't build the trust that's necessary to get women to receive pre-exposure prophylaxis to take the medication. Right, so sort of giving you all this is the history, right? And now to think about where are we now and what are the challenges that we're currently facing that we need to continue to address. It's 2026, right? We have a lot of knowledge about pre-exposure prophylaxis and its ability to help us address the HIV epidemic. We know that it is nearly 100% effective. It is widely recommended by infectious disease societies, by HIV providers, by internal medicine organizations, and we have even better ways of getting it out to folks, right? We have long-acting injectable options that help us get the medication in the arms of individuals who are at risk, and it provides them, in some cases, 6 months of protection. It gives us this huge window of providing them the protection against HIV acquisition. What I'm showing on the right are the two studies that came out of lenacapavir, which is the 6-month long-acting injectable. The Purpose 1 study was done in cisgender women. We learned our lesson. We studied the drug in a population at risk, and that showed actually 0 cases of HIV transmission in women who were on lenacapavir. And then Purpose 2, which is on the right, was a study of men who have sex with men and transgender women, which showed nearly similar efficacy of the drug in reducing the risk of HIV. So we have this great medication. We studied it in the right way. And yet, we still are not moving the needle when it comes to HIV incidence and viral suppression. Right? So sort of updating those CDC data that I shared with you before. These are now data from 2022, published in 2024. Right in the top, we have incidence of HIV in the US, where we still see Black and Latino individuals, in particular, Black and Latino men who have sex with men, with the highest incidence of HIV. And the bottom right is a figure that tries to look at the care cascade for HIV to understand, right, if we've identified folks with HIV, are we getting them into care, and are we getting them virally suppressed by getting them on medications? When we're doing a slightly better job at getting folks tested, getting them into care, we still have disparities when it comes to viral suppression. And the other thing that I think is important for us to remember, and I said we want to talk about how these infectious diseases evolve, is that the HIV epidemic is different in 2026 than it was in 2012. In 2012, those initial pre-exposure prophylaxis studies were all done largely in men who have sex with men, because that is where the predominant risk was. And while that's still the case, there is a growing risk in people who inject drugs. And we continue to see pretty stable numbers of new incident HIV cases in people who inject drugs, which means we have to change the way that we deliver care, change the way that we design the clinical trials to study the interventions, change where we do the work, right? Thinking about harm reduction organizations, community health centers that bring people in for methadone and hepatitis C treatment, also engaging in pre-exposure prophylaxis. And so thinking about how we build equity into each part of that cascade and how we adapt and evolve with the changing epidemic that exists. Okay, we're going to move on to the next infectious disease, which is one that you're all, I'm sure, very familiar with, COVID, and one that, there are moments in your career that are really formative, and this, for me, was an incredibly formative moment. Partly because I'm an infectious disease doctor, and this is a once-in-a-lifetime pandemic, and it happened, and obviously I was called to respond to it, but partly because I was called to respond at CDC, and I was at the federal government right at the time, as many decisions had to be made about how we think about the pandemic, how we respond, how we do so in an equitable manner. So let's kind of go back to 2020. Think about where we were when this disease first presented nearly 6 years ago to the day. It was actually, I think, December 2019 when the first case presented. But this cases started to come to the United States February, March of 2020. There was a tremendous amount of uncertainty. Right? We didn't know how the disease was transmitted. We had no clue how to prevent transmission. We didn't really understand severity of the disease, who was going to be at risk, who was going to end up in the hospital. There were significant gaps in trust because when things are ambiguous and people go out on TV or go out in front of large crowds and start talking authoritatively, and then the next day have to walk it back, it really destroys the trust that you have with those who are giving out that information. We knew that we had to rapidly scale up what we were doing, right? The entire country, 360 million Americans, needed a public health response instantly, overnight. And we were not built for that in any way. We weren't built to do the science the way that we needed to do in the setting of a pandemic, right? If you think about, now it's so common to think about preprints and moving science so quickly, but in 2018, 2019, we weren't putting out figures on Twitter. Like medical Twitter wasn't a thing yet. We weren't sharing information as rapidly as we possibly could because it could change the way that we treated the disease the next day. The scientific machinery had to adapt to where we were. We also, I think, we should have known, we should have been fully cognizant of this because of our experience with other infectious diseases, but we should have known that there was going to be a disproportionate impact on communities of color here in the United States because of the system that we had set up, right? Because we had a system that had limited access to care for many of those communities, limited access to treatment. And that really was the truth. You can't see over here on the right because I cut off the figure, I apologize, or the legend on this, I apologize, is a curve of hospitalized patients with COVID by race and ethnicity. And that line at the bottom is white individuals. And all of the lines at the top are individuals of color, whether it be Black, Latino, American Indian, Alaska Native, or other Pacific Islanders. There was a higher percentage of those individuals who were being admitted to hospitals for COVID, right, because of the system that we had. And I think in 2020, there was a tremendous amount of effort that went into thinking about, okay, we saw this right at the beginning, March, April, May. We knew that there was this disproportionate impact on communities of color. How are we going to respond better? How is the public health system and the scientific machinery going to respond better to this? And we had a lot of opportunities to practice, right? Remdesivir came out, a treatment, and we had to think about how do we deliver this treatment in a way that is equitable. Monoclonal antibodies came out, and we had to think really quickly about how we were going to deliver monoclonal antibodies in an equitable way. And this was, again, a moment in my career where I felt sort of called to put out some thoughts, to put out my perspective, because I was worried about the numbers, the figure that I had shown you on the prior slide. I was worried about our ability to respond equitably to a crisis. So for folks who were maybe not as engaged with the monoclonal antibody discussion back in 2020, right, pharmaceutical companies were starting to produce these monoclonal antibodies that could be an effective treatment for those with COVID-19. That said, there were very few of them produced. There was a significant limitation on the quantity that was being produced. We didn't have a lot of information. There was this sort of phenomena that happened during the COVID pandemic where we really heavily relied on emergency use authorization from the Food and Drug Administration, an EUA. This is a process that existed, but it had lacked a lot of transparency. It meant that there were only limited data presented to FDA. Those limited data were used to make some decisions about who might benefit from the intervention, and it was authorized for use following that review. Oftentimes, we were getting data out of press releases, not out of scientific publications. We were pulling data from a tweet or a news article rather than pulling it from the New England Journal of Medicine or another publication. We really understood that there could be tremendous benefit to monoclonal antibodies, but the limitations were significant. So the supply was going to be really challenging to get around. The requirement for an outpatient infusion was an enormous barrier because it meant people had to come into a clinical setting, right? And I had said to you sort of on the prior slide, we had not built the clinical settings in Black and brown communities. We had not built them in the communities of those most vulnerable. We'd built them in other areas. And there were cost barriers related to insurance and some insurance gaps that really worsened the disparities that we saw in COVID diagnosis, COVID admissions, and eventually in monoclonal antibody administration. And so this article, which I believe I also shared with you, provides some insight in how we can innovate, which was really important in the setting of a pandemic, but do so while we think about equitable distribution and equitable access so that we don't end up having what happened with PrEP happen in the next infectious disease outbreak or in the next threat that we have to go through. And so this paper came out in December of 2020. I wrote it with Rochelle Walensky, who at the time was my boss at Mass General Hospital. And we wrote it focused on monoclonal antibodies, but we knew that as soon as this was published, within the next week, there was going to be our biggest test yet, which was vaccine distribution for COVID-19. Right? The news releases were coming out that the vaccines worked. The New England Journal paper had not yet been published, but the press release had been put out that the vaccines were effective. And we were hopeful that we would take some lessons from our experience with monoclonal antibodies and adapt them to the vaccine response. And you probably know this, but the reality is we didn't necessarily take any of those lessons into account. This is a figure that I really, really love from this MMWR in 2022 that looks at COVID-19 vaccine coverage. And the line in the middle is a comparison to white non-Hispanic adults in the United States. And it looks over time from the release of the vaccines in December of 2020 until the following November 2021, and compares vaccine coverage in various race and ethnicity groups. And in all of them, except for in Asian individuals, you can see that there was this initial drop in comparison to white individuals, right? So Hispanic individuals, Black, Pacific Islander, American Indian and Alaska Native individuals were all lower than white. And it took time for us to get vaccines out to those populations. Despite the fact that we sort of knew what was going to happen, we just experienced it with monoclonals. We knew what was going to happen. We had experienced it with HIV. We had experienced it with almost every infectious disease outbreak. I think there are some lessons in this slide. One is that you see that over time, those groups did come up to the level of white adults in the United States. And I think that's a result of a lot of effort by, I'll sort of say CDC did a lot in that time to get folks vaccinated in their community. This meant local vaccine clinics. It meant partnering with pharmacies in local communities. It meant getting trusted messengers out there. It meant engaging with people and addressing some of those mistrust issues that keep people from care. But these lessons that we learned and some of the work that we implemented, unfortunately, we have not maintained. And these are data from Massachusetts. If we look 2023, 2024, 2025 respiratory seasons, and this is the percentage of the population of Massachusetts residents who were vaccinated for COVID-19 in each of those seasons. And what you can see is that in every season, Black and brown communities are lower than white communities. And over time, we have almost in every group had a decrease in the percentage of the population that's got vaccinated for COVID. And I think this highlights that while we did a lot of work in 2021 to try to get people vaccinated, to build trust, to get into communities, to address a pandemic as it was progressing, we haven't necessarily maintained those investments in the way that we need to, and we're not seeing the benefit in the way that we would have hoped to. So there's a lot of work to do still. That 12.4% really bothers me. These numbers are updated as of last week. So this is actually where we are right now in Massachusetts. We are at incredibly low rates across the board for COVID vaccination uptake. Okay, we're going to move on to an interesting disease that I will say taught me a lot of lessons and resulted in a lot of tears. I'm happy to explain that later. So I will say going into 2022, I was an infectious disease fellow, I was an infectious disease doctor. I thought about what was then called monkeypox, now called mpox, when I studied for my boards. It was not something that you saw in the emergency room. It was not a disease that you really contemplated in your differential diagnosis of someone coming in with a rash and a lesion. And then everything changed in May of 2022, right? It just completely changed. It was really amazing, and I mean that truly, to be at CDC in May and June of 2022 as we saw this outbreak happening across the world and coming here to the United States. And to be there between June and August when it felt as if that increase in the epi curve would never end. That cases would just continue to go up and up and up and up and up, and we would never find a way out of this outbreak. There were a lot of unknowns or a lot of interesting questions at that time. In the beginning, we didn't know if we should classify this as a sexually transmitted infection. Seems like kind of an obvious question and answer right now, but it wasn't clear in May and June of 2022. We knew there was spread in the MSM community. We knew that spread was happening after sexual acts, but it wasn't clear exactly how transmission was happening of the virus and who was at risk. We didn't know how to protect people. So I don't have it on the slide, but there was this probably a week-long discussion in mid-June about how to change people's behavior, because we thought that was the only way that we were going to prevent the spread of the outbreak. So we had sort of landed on that this was a sexually transmitted infection, and now how do we tell people to basically stop having sex? Or if you are going to have sex, here are the ways to have sex in a safer way that would protect you from this. We had these vaccines that were sitting in the strategic national stockpile that no one really knew what to do with. We expected them to be protective, but we didn't have a lot of clinical data. There are 2 vaccines. We'll talk about this in another slide. But we had a very, very limited supply of the vaccines. And then we had no FDA-approved treatment for this disease that was causing significant morbidity, a lot of pain, a lot of suffering, a lot of folks ending up in the hospital because of their lesions. So one of the lessons of that time for me was to sort of take a step back and to think, in the middle of an infectious disease threat, in the middle of a public health crisis, it is the time to build the evidence base. It is the time to ask the critical questions and to make sure that what we're doing is scientifically sound. So, I think a really good example here is that we did not know how the antibody or the vaccines that we had, how they were going to react in the real world. So all we really knew was that there were 2 vaccines for smallpox, which is a related virus to mpox. One was called ACAM2000, and the other one was a vaccine called Jynneos. ACAM2000 had been studied, and we knew it was not great. You couldn't give it to people who are immunocompromised because it could cause death. That's probably a bad side effect of a vaccine. We don't want to do that. You couldn't give it to someone who lived with someone who was immunocompromised because it could infect the other person. So there were a lot of downsides to ACAM2000. And then we had this other vaccine, Jynneos, that had only been studied in this New England Journal of Medicine paper, regarded institution, but a study of 440 healthy volunteers who were vaccinated with ACAM2000 and with Jynneos. And we knew that the Jynneos vaccine here, called MVA, was non-inferior to ACAM2000 after the second dose based on antibody titers. That's all we knew. That was everything we had available to understand the efficacy of this vaccine. We knew it was safe because the 440 volunteers did well with the vaccine. So we thought, at least in that group, this is a safe vaccine. But we really did not know if it would protect someone if they were exposed to smallpox or, in this case, to mpox. And so, again, this sort of made me think about, okay, well, what are you supposed to do when you don't have this information? And the reality is we actually don't have great data for any medical countermeasures that are designed for use in emergencies. And that is almost by design, right? These are emergencies. They're rare events, we hope. They oftentimes are the result of life-threatening infections, right? Smallpox has a significant mortality associated with it. And so we're not going to infect people with smallpox and see if we can protect them. That would be unethical. And we actually hope that we don't have a bunch of smallpox or mpox outbreaks that happen so that we can continue to study the vaccines. So we end up relying on these surrogate markers. We end up relying on things like antibody response. We use animal models through what I'll describe in a little bit, the FDA animal rule, to give us some sense of maybe this might work in humans. But in the moment, we really have to think about how can we, as a public health ecosystem, balance our need for data so that we understand the effectiveness of our interventions, and also our desire to put something out there and to provide prevention and treatment, right? Like, is it ethical to do a randomized controlled double-blinded trial in the middle of an outbreak? It's an interesting question. I have an answer. You might have a different answer than me, but I think it's an interesting question. Do you withhold the prevention and treatment available because we think it might work, or do you study it and risk some people getting sick because we want to know definitively if it does work? And I think in the case of mpox, we challenged some assumptions, and we tried to answer this question. And we did it with vaccines. These are two studies that came out. And actually, the date of publication, I think, is not a great reflection of when the data actually were available and were being used. The top corner is from an MMWR published in 2023, the bottom from a New England Journal of Medicine paper in 2023. Both looked at folks who were vaccinated or unvaccinated with mpox in the early part of the outbreak, so August to March or August to November of the outbreak, to see if the vaccine was effective. We actually set up the system really quickly, and I'm really proud of work that happened across public health and state departments of public health, at CDC and other places, to be able to actually figure out, is the vaccine effective at doing what we hope it does? And it turns out it was. The vaccine was effective. And we could do it actually in case control studies here, where we didn't have to randomize people, we didn't have to give people placebo. We could do it in a way that provided us reassurance the vaccine is effective, and we weren't withholding treatment from anyone. I will just sort of make a parenthetical note that some of the same issues I described with COVID and with HIV at getting interventions out equitably were an issue here. This is a look at the entire outbreak from May until December, and looks at when we confirmed the cases, when we started to do increased testing, when we started to get vaccines out. And then you can see the vaccination rates in Black and Latino individuals compared to white individuals. That's on the bottom. And then also the incidence in those. And we really did struggle to get vaccines out into the Black and brown communities. This is another way of looking at that, which is vaccination to case ratios. That in the beginning, there was a lot of vaccination that was going out into white communities, even though the white communities weren't the communities with the cases. And it took us a while to get to a place where we really started to get vaccine out into Black and brown communities. But sort of to say, a lot of the same discussion points from HIV and COVID can be seen in the mpox response. But I think a place where we really tried to do the right thing to build the evidence base was in understanding treatment, potential treatment for mpox. So just to sort of explain what we knew in 2022 was that there was a drug called tecovirimat, or TPOXX, that had been studied for the treatment of smallpox. This drug was studied in 2 animal models of disease. A model of mpox, or monkeypox, in non-human primates, and rabbitpox in rabbits. And both models, both animal models, proved that the drug was efficacious. And then there were subsequent studies of testing the drug in humans that showed it was safe. And because of this, this drug, tecovirimat, got approved by the FDA for use against smallpox. Right? So just to say this, we studied monkeypox in non-human primates, rabbitpox in rabbits, and the drug got approved for smallpox. Okay, that is bizarre, I think. And it's because of this sort of weird thing that FDA has had on the books for a while, which is that you can use the animal rule to approve therapies. And the animal rule says that FDA is allowed to approve a drug when human efficacy studies are not ethical. Interestingly, the and is intentional. And when field trials to study the effectiveness of the drug or the biologic product is not feasible. Right? And so in this case for smallpox, it was not ethical to infect people with smallpox. Like we can all agree on that. And there were not field trials, right? There's not, smallpox is eradicated. It's not anywhere. We can't go out and set up a randomized control trial. And so FDA approved TPOXX, tecovirimat, based on the animal rule. And so we had it available. But we actually did not know if it would work for smallpox, but we also didn't know if it would work for Mpox, right? We had never studied it in a human, and all we had was a compassionate use of the medication. And so there were randomized controlled trials that were set up in the middle of an outbreak to help us understand whether this intervention was effective. The first was STOMP, which was done largely here in the United States, and it was a phase 3 clinical trial of TPOXX for Mpox, clade 2, which was what was circulating during the 2022 outbreak. The goal was to enroll 500 people with mild to moderate disease across 80 sites, mostly here in the US, and to randomize them to treatment or placebo 2-to-1. It allowed for compassionate use of the medication. So if you had someone severely immunocompromised, someone with severe disease, ocular disease, they could be given tecovirimat and observed, but not be included in the randomization. And the outcome was to look at time to resolution, pain, and resistance to the medication. And around the same time, a separate RCT was set up in the DRC that was focused on clade 1 of Mpox, which was a different strain of Mpox, but was believed to also could possibly be treated by tecovirimat. And this was nearly 600 people randomized with confirmed disease, and the outcome of interest was resolution of the lesions. And what was interesting is that I think we were all hopeful that we were going to confirm our bias here. We were going to confirm that this was a medication that worked and we should get it out the door. And it turns out we were wrong. And the NIH study found that the drug was safe, but that it didn't improve time to resolution or pain. And the study in the DRC showed no benefit compared to placebo. And to me, this was disappointing, but also exactly what we needed in that moment. Because we needed to understand if this was a drug that worked. And we demonstrated, I think, to the scientific community that yes, you can ethically run a randomized controlled trial of a public health intervention in the middle of a public health crisis. We can build the evidence base while we are responding. And I think we did so responsibly and ethically. We did it with a lot of people watching. But I think it was important for us to do these studies, to do these trials, and now to incorporate it into our public health response. Okay, I'm running a little bit long, so I'm going to go quickly through this last piece, but I cannot talk to anyone in public health and not talk about vaccine-preventable diseases in 2026. So I want to maybe share with you the good news, and this is sort of like looking back at Massachusetts, looking at the good things that have happened. So what have we known for a long time? Here in Massachusetts, we've known that vaccines are incredibly effective and that vaccines are good, and that we want kids to be vaccinated. And what you're seeing here is over time, this is looking at kindergarten immunization rate. So every student in Massachusetts public schools is required to be vaccinated. That needs to be documented and sent to the Department of Public Health. And so you can look over that 25-year period. In red, you have hepatitis B, 3 shots of hepatitis B. In green, 2 shots of MMR. In blue, 4 shots of polio. And then in yellow, the whole childhood series. And our rates have been remarkably stable. Just take note of the x-axis. It goes from 100 to 88. So we're really kind of scrunched in here. But we have had remarkably stable rates of child immunization here in Massachusetts. And I'm really proud of that. We should all be proud of that because we live in the Commonwealth. And I think we have a lot of reasons why this is true. And we still have work to do. And this might be a little bit harder to see with the small numbers, but what the shading here shows on the left are kindergarten students who had an exemption, right, whose parents filed a reason why that child should not be vaccinated. Darker colors are higher numbers of exemptions, and there are parts of our state where the exemption rate is pretty high, up to 4% in some parts of the state, like in the Vineyard. And then on the right, we have the proportion of kindergarten students who are not meeting all school requirements, who haven't completed the full series. And again, while overall our statewide completion rate is pretty high, there are parts of the state where completion rates are really low. Berkshire County is around 9% of students have not completed, and there are parts of Berkshire County that have even higher rates of students. There are schools in Berkshire County, in particular private schools, that have close to 60 to 70% of folks who are not vaccinated. It's the flip of what we would have wanted. Right, so still work to do here. But I think we have to compare that and contrast that to what's happening at the federal level and what's happening around the country. And this, unless you've not picked up a newspaper in the past year, I think you're aware of what is shown on this slide, which is that on the left, the rates of MMR vaccination have decreased dramatically in this country over the past 10 years. That's what's shown in the lines, in the blue lines. And then as a result of that, we are now experiencing the consequences. So we're seeing an increase already in measles cases across the country. And now we are at nearly 3,000 measles cases since the beginning of 2025 here in the United States. And this sort of shows you, by scale of the circle, the size of those outbreaks. I will say I've talked to Jen Schufert, who's the Commissioner of Public Health in Texas, and this has been incredibly challenging for her. I've talked to Brandon Taxler, who's the Commissioner in South Carolina, and it has brought her to tears, the outbreak that is happening in South Carolina. It is almost exclusively happening in unvaccinated individuals and in unvaccinated communities. And it is very clearly a preventable disease if only folks would get vaccines. And at the risk of getting too political, I will just say this is, there are consequences to words and there are consequences to actions, and those consequences have real life-impacting outcomes. And what we've seen just in the past 3 months are groups putting out false assertions about the measles outbreak and false assertions about what works to treat measles and to prevent measles. We're seeing federal panels that are being swayed by these groups and these false assertions and the lack of evidence that they're presenting. They're changing recommendations. In particular, the hepatitis B vaccine was removed from the birth recommendations back in December. And we're seeing the federal government itself, right, through the Secretary Kennedy, unilaterally making decisions about recommendations for vaccines. And this has a huge impact on who will get vaccinated. It has an impact on people's trust with public health. It will, I think, have repercussions for decades to come as we in public health try to address the outbreaks that we're going to have to address and the challenges that we're going to have to face, because the trust has been destroyed as we have seen this sort of mis and disinformation propagate and proliferate across the country. And on that incredibly sour note, I will say thank you. And I did not leave a ton of time for discussion, but I'm happy to answer any questions that you might have. Thank you so much for joining us. We do have some time for questions. We can take any questions from the room, and I'll look on Zoom as well.
One question for person I'm assuming.
Yeah.
One question for person, because I'm so curious.
Yeah.
But I will start with sort of whether or not you have data on the effective education level and income level on vaccine uptake. And the flip side to that is like if it's so well established at this point that there are certain communities that are vulnerable more than others due to structural reasons or whatever, like socioeconomic, right? Like why is it that it is not like they're not identified as a vulnerable category and they're always the ones who get treatment first? Like, I don't understand.
Yeah. Yeah. So to answer the first question, I don't have it in my head, the correlation with income and education level when it comes to vaccination. Actually, know that one of the largest, specifically talking about Texas and South Carolina, the largest predictor of people who are unvaccinated, people who are at risk for the measles outbreak, is about religious affiliation, and there are particular religious groups that have more the community, I would say, than the religion, because there's actually no religion that says you can't be vaccinated, but the communities around the religion it's the greatest predictor of who's going to be at risk. And so South Carolina in particular has really tried to go in and talk to faith leaders and talk to folks who might have influence in those religious communities. On the second question, I mean, I think that's the $20,000 question of public health. Like we keep seeing this over and over again, and we know that when we build a better system, we build something that is more equitable, we won't see the disparate outcomes, especially at the beginning of a particular outbreak. Part of the problem is that it's expensive to build those systems, and public health is chronically underfunded, so we don't have the money to build and sustain what we need to do that work. And then we lack the trust that we need to be able to get out there at the start of a threat or an outbreak. And I don't blame people for not trusting us, because each time, repeatedly, we have left the most vulnerable out of the system, right? And so we keep reinforcing the distrust that they have for us. So we really do, there's a lot of work that needs to be done here. This is not a, one-time investment. We'll build a new system and everything will be fine, which is a little bit what we tried with COVID. This is sustained investment, sustained engagement with communities, sustained building of trust.
Thanks very much. That was great. I had a question, not from a political perspective, but just from a logistical perspective. It's striking how much of the science that you talked about that you do during outbreaks and responses is in partnership with the CDC and the FDA, and you can imagine now that priorities might be different. What is the ability of a state DPH to, for example, do the Mpox trials that you did independently as a state DPH without kind of CDC, FDA? I imagine there's regulatory barriers that would.
Yeah.
And I would just say that's particularly important given the FDA's current stated attitudes towards RCTs, observational data, and so on.
Yeah. So I actually don't know how to best manage the current administration and the current FDA, because I'm it's not logical, and they're not following a precedent that makes sense, even though there are some parts of FDA that have never made sense to me, like the animal rule. But let me give you some examples of how.
Like a public health infrastructure.
Yeah, like how can states do this? And so let me give you maybe 3 examples here. One is from COVID. Right, when in the fall of 2021, everybody needed to understand, summer into fall of 2021, needed to understand the effectiveness of vaccines and their ability to last, that the ability for a vaccine effectiveness to persist. There was no federal system in place to do that here in the United States. So we had a few options. We could look to Israel, which had a system that could look at every case, every person who was vaccinated, and understand vaccine effectiveness. And we did. We looked to Israel. They were incredibly helpful. We could look to the manufacturers because they do post-marketing research, and they continued to evaluate the antibody response and try to understand what was happening to people's ability to respond to the infection. Or we could look to the states, because individual states had access to the data that could tell us if the vaccine was effective. And in particular, in August and September of 2021, it was New York State that had set up a system that could look at cases and controls and had the ability to bring in their immunization records so that we knew who was vaccinated, who was not vaccinated. And I can sort of like tell you from being in that room, the decision to recommend a booster dose in September of 2021 was based on those 3 data sources. There was no CDC data set that told us that the vaccine effectiveness was waning. There was no FDA data set that was telling us that the vaccine effectiveness was waning. It was that we looked to Israel, we looked to the manufacturers, and we had data from New York. I think a second example is if we think about the Delta wave that happened. So if you remember like Alpha and all these different letters that were associated with the COVID pandemic, but the Delta wave happened in the summer of 2021. Everyone got vaccinated, everyone took their masks off, everyone thought, okay, we're done, this pandemic is over. And then it was actually here in Massachusetts, out in Barnstable County, where cases in vaccinated individuals started to present. And it was the State Department of Public Health. I wasn't here I wasn't in Massachusetts, I was at CDC, but it was the State Department of Public Health that went out and did the contact tracing, obtained all of the data, analyzed the genomics of the virus, understood what was happening, and could describe actually what we needed to do. And the public health intervention at that time was put your mask back on, even if you're vaccinated, right? And so it was the state that actually resulted in that response. And then the third example I'll just say is in those Mpox data that I showed you from MMWR, while it was published by CDC, that was the New York State system that was just brought up to CDC and then implemented across other states. And so we used what New York had already done to build the right case control model and to understand vaccine effectiveness. So it was a long way of saying the states actually have all of the data. They have a lot of the power to understand public health threats and the effectiveness of our response to those threats. The federal government previously was willing to and interested in hearing from the states. I just don't know how this current administration would respond.
I wonder if there's some value in like adaptive platform trials for this space, because, for example, during COVID, Remap Cap was able to then add additional domains for steroids and for tocilizumab and all these other things that we eventually injected clinically. Has the Department of Massachusetts or like the I guess greater public health community thought about that as a preparedness tool for these trials?
Yes. So, yes, I would say that the State Department of Public Health, we don't run large clinical trials. We try to analyze the data, but I think that the hospital system here in Massachusetts understood that and understood the need to respond to the pandemic. So, right in 2020, I guess this was, as all those monoclonal antibodies were coming out, as remdesivir was coming out, as steroids were being considered, as hydroxychloroquine was being considered, the hospital system here tried to figure out a way to adapt each clinical trial, to add in different pieces, to meld things together so that we could get the best picture of what was happening and then rapidly publish data and get it out. Yes, I think public health, the healthcare system has bought into that concept. It's just incredibly challenging to do. I was at MGH at the time, and the way that was done was like sort of top-down authority of you must, if you're going to do a clinical trial here, you must be part of this network, and you must be included. every day, every individual coming with COVID was being considered for all the different clinical trials and figuring out how they could crisscross and we could understand the effectiveness of interventions. But it's not easy to do.
Any last questions? I think we're just about out of time.
Sure. Okay. If you had a wish list for academic institutions in Massachusetts, like how could we serve in DPH better?
Oh, it's a great question. So I'm going to say something, and I both want it and also don't want it. But one lesson that I've learned transitioning from being in the academic world to being in governmental public health is to recognize that we have to move incredibly quickly. And we've demonstrated that we can do that with COVID, with Mpox, right? Academia sometimes doesn't do that. And I brought up the example of the STOMP trial. I think it was pretty remarkable that we got academia to, it was really driven by academia. It was done through the AIDS Clinical Trial Group, which is largely academic medical centers and researchers. We got them to stand up this clinical trial, start to enroll, and start to get data within months of the start of an outbreak. That is pretty incredible that we were able to do that. And when I say we, I mean sort of public health writ large. That speed is what's necessary from academia. That said, the reason why it's like both true and not true is like sometimes people do need to take a huge step back, because in the Department of Public Health, we get kind of caught in the everyday of program implementation, and we forget that it is important to take the step back and question if we're doing the right thing, if we've studied it appropriately, if there's a better way for us to do it, and academia is probably better positioned to ask those questions.
Thank you, everyone. Thank you again, Dr. Goldstein, for visiting us.
Yeah.
And,
Thank you for having me.
that concludes today's seminar.
Great.